So we will move from the too fast heart to the too.
Thank you.
I don't know the name in English. Finally, it's not too fast. It's too. There is a problem of conduction. Finally, so David, you will talk about all the device you can find in a heart to accelerate its rate. Thank you, David, for your presentation.
Thank you, Dr. Rozek, for letting me speaking, and thank you everyone for inviting me to address the subject of perioperative management for patients with cardiac implantable devices. So I do not have any conflict of interest on the subject. I would like to start with some key messages. So the first thing I think is that we should acknowledge that cardiac electrophysiology is complex. It is complex because of the different indication, the different type of manufacturers and devices and even settings. But we should also say that the perioperative care of those patients should not be complex. So how can we reach this objective? So I think that the first important thing is to try to manage in an individualized way and multidisciplinary approach. So between anesthesiologists, EP cardiologists, and surgeons. Try to establish also a protocolized, even for emergency surgeries, and anticipate our disposition, both in the pre, intra, and post-operative period. We should also acknowledge that the recommendation from the physician who usually manage or monitor the devices will be the best recommendation. And this is well recognized by recent guidelines, both from anesthesiologists and cardiologists, that clearly indicate that it is recommended for every hospital to nominate a person, a cardiologist, who will be responsible for programming the devices. We want to avoid adverse events. So there are three different categories of adverse events. So of course, the first one are the electromagnetic interferences that may be responsible for inappropriate therapy, reset mode, magnet mode. The second category is the direct damage to the device, to the LEDs or LED implantation that may induce an inability to deliver therapy, also alter the battery life of the device. And finally, maybe the more severe is the device infection that may be provoked by any type of bacteremia. And we should remember that this type of infection the prognosis is very severe with up to 35% of mortality. So all those adverse events will cause a different type of cardiovascular adverse event can may be severe. And of course, at the end, some kind of clinical and economic burden with indication for device replacement, increased medical costs, and even sometimes mortality. So speaking about interferences during pacemaker, we should know that any type of radio frequency wave between 0 to 1 gigahertz can produce this type of interferences. Of course, modern devices are less susceptible. And most of the time for pacemaker, we will have a problem of inhibition of pacing. And this is secondary to oversensing, meaning that the pacemaker will interpret the interferences as a regular heart rhythm and stop its activity. And this, of course, will be responsible for severe bradycardia, as shown here, or even asystole. More rarely, we can have a phenomenon of overpacing that is secondary to undersensing of the pacemaker of regular activity. So overpacing may be very dangerous on the hemodynamical point of view if the stimulation of the pacemaker fall on the T wave. This is maybe responsible for the phenomenon R on T that may produce severe ventricular arrhythmia. Considering the implantable cardioverter defibrillators, the most problem that we have with interferences will be an inappropriate or oversensing of the device that will produce an inappropriate shock. So inappropriate shock can be responsible for damage in the myocardium, for bradytachyarrhythmia, particularly if, of course, the shock fall on the T waves, and also battery consumption. And this is very important, like consuming the battery of a device may reduce the lifetime of that device. And we know that it may be complex to exchange this type of device for cardiologists. So to estimate the risk of interferences, mainly two factors are important. The first one is the use of monopolar surgery, electrosurgery, and the second one is radiofrequency. And this risk will be very likely if the surgery happens superior to the umbilicus. And it will be critical if it happens less than 20 centimeters from the device. We should also know that we can use peripheral nerve stimulator for local regional anesthesia. This is safe. And special care to the mobile phones. So usually the recommendation is not use mobile phone next to a generator. And this is specifically true for the last generation iPhone 12 and MagSafe device that will simply and purely activate the magnet mode, meaning that they will inactivate ICDs. And this has been well described in recent case report. So in the preoperative period, we should assess the presence of a device first and then try to elucidate the type indication manufacturer. So some patient may have a type of card, some not. Sometimes it's written in the medical record, sometimes not. So if you don't have access to the type of information, I advise you to proceed to a chest X-ray. Chest X-ray will give you the position of the device, the number of lead. So you can see here that you have like a regular dual pacemaker. See if you see coils that correspond to kind of wider portion in the leads. This is the signature of the presence of a defibrillator in your device. And this also will be very interesting. And if you have coils plus 3 different type of leads, it's very probable that you have a CRTD, so a resuscitation therapy. Second aspect in the preoperative period is to determine if your patient is pacemaker dependent. So if it shows no spontaneous ventricular activity at the lowest programmable rate. And this of course can be fine if the patient has received an interrogation, which would be the case every 6 or 12 months. But if you don't have access to that information, you can just proceed to a preoperative ECG and look for spikes. So spikes correspond to the pacing stimulus artifact, and you can have like atrial spikes, ventricular spikes, or AV spikes. And if this is constant over a certain period of time, that will show you or give a good indication that your patient is pacemaker dependent. So what are the indications of reprogramming before surgery? So for pacemaker, if you have a risk of intraoperative electromagnetic interference that is likely, so basically the monopolar or radiofrequency above the umbilicus, plus a patient that is pacing dependent, you need to alter the pacemaker function to an asynchronous mode before surgery. So this should be done right before anesthesia induction, ideally with the cardiologist, and check for a good capture and a good hemodynamic stability. For ICD or CRTD, the first rule to remember is that all ICDs, all this type of device also include a pacemaker. And this basically is used to stimulate in case of post-shock bradyarrhythmia. So if you have a patient that have an ICD and the risk of intraoperative interferences that is likely, you will have to suspend. It will be safer to suspend the anti-tachycardia function of your device. And 2 situations in that case. If the patient is not pacing dependent, you can use, of course, your cardiologist or a magnet. If the patient is pacing dependent, the reprogramming will be mandatory because the magnet cannot alter a pacemaker function in an ICD, which is not, of course, the case for a regular pacemaker. So deactivating an ICD should be done in monitoring environment and be prepared for a backup cardioversion. So about the magnet, so the application is supposed to alter the pacing function to asynchronous mode, only for pacemaker, not for ICD, very important, and suspend tachycardia function for ICDs. Some of them, like the Medtronic and Boston Scientific, can also emit a kind of audible tone, proving that the ICD is actually deactivated. So magnets should be limited to rescue indications. If you don't have access to a cardiologist for a preoperative reprogramming or for emergency surgery, you have to know that the effect is actually easily reversed when you remove the magnet. You can secure it with tape, it will be safer, and think that if your surgery is in prone position, magnet is not an option for you. Finally, always remember that the indiscriminate use of magnet should be avoided because the risk of failure and suboptimal effect is real. During surgery, we should monitor both ECG and heart rate. As shown here, your heart rate with interferences can show you like tachycardia or normal frequency, while the heart rate measured with SpO2 or invasive arterial pressure will show you the bradycardia. So set your alarm on the heart rate measure on SpO2 or on the arteries. How to minimize the risk of interferences during electrosurgery. So if you can, of course, use bipolar or ultrasonic with the risk of interference that is very low. Optimize the position of the pad for the unipolar surgery on the right side if you can. For head and neck surgery on the contralateral shoulder, use short intermittent irregular burst at the lowest energy as possible, and prefer the cutting energy as compared to the coagulation current. How do we do if we need to defibrillate a patient with a deactivated ICD? So if you deactivate the ICD with a magnet, the safest way is just to remove the magnet and let the ICD do. You have to know that a current ICDs terminate a VFib in more than 98% of the case. If the ICD has been deactivated by a cardiologist, you need to proceed to emergency external defibrillation. So the better pad position that should be put in place before anesthesia induction is the anterior-posterior pad position. And please try to respect 15 centimeter distance between the pad and the generator, because you can induce a problem in the device and to the myocardium if you shock directly over the device. Please also use the same energy levels as supposed to do according to the guidelines. So small tips about the non-electromagnetic risks. So for CVC, choose always the lead site away from the lead implantation. For PA catheter, be very, very careful if the device has been implanted in less than 6 weeks, because the risk of dislodging the lead is real. Always manage normal acid base and electric status, and care for infection. So caring for infection is, the regular precaution, and be very strict on the antibiotic guidelines in those patients. And finally, caution to volemia, because patients with pacemaker are not able to respond to a volemia with tachycardia. So fixed heart rate can produce a problem in case of hypovolemia. And finally, for the postoperative period, we should remember about the indication of postoperative device interrogations. So if you have any type of this issue, like the device has been reprogrammed before during surgery, you have an emergency surgery above the umbilicus, you deliver any kind of therapy, shock, temporary pacing, anticardiac therapy, you proceed to a cardiopulmonary resuscitation during surgery, you face significant interferences for all type of procedural risks, meaning cardiothoracic and aortic aneurysm repair, radiofrequency, electroconvulsive therapy, or the use of a pulmonary catheter, it will be safer to interrogate the device after surgery. And for example, if you deactivate an ICD, this will require maintaining, monitoring, and backup cardioversion equipment until the postoperative interrogation and the restoration of the full permanent setting is done. So this may require an ICU stay or a stay in a telemetry unit. If you don't have any of this indication, you can proceed regularly and schedule a meeting with the cardiologist 30 days after the procedure. So to conclude, 10 take-home messages. So the first one is you need to identify the specialist in your hospital. This is very important, maybe the most important. Preoperatively, we need to answer to 2 questions. Is the patient pacing dependent, and is there a defibrillator function? Actually, in emergency, you can answer to those questions by proceeding to ECG, looking for spikes, and chest X-ray, looking for coils. Individualized preoperative reprogramming is clearly superior to the magnet for all strategy. Anticipate and minimize the intraoperative interferences. And remember that the risk is very high for the monopolar cautery above the umbilicus, critical below 20 centimeter. Think of the monitored environment and the backup devices for pacing and defibrillation that should be readily available. Prevention of damage of the device and infection, and good care with the use of CVC. And finally, think about the postoperative telemetry if there is an indication. And I must recommend you to read the recent guidelines that have been published by the American Society in Anesthesiology. Thank you very much.
Thank you very much, David, for this very, very clear presentation. I've got one personal question. There is more and more wireless, leadless system. It is interesting. Will we see this system more and more frequently or not? What is your opinion about that?
I mean, for the future indication, I don't have a clear opinion of that. What I can say that in the current guidelines, there are no specific recommendation for this type of device. So I would say that so far we should use the same strategy as for the regular pacemakers. So those leadless, basically the generator is inside the cardiac cavity. So I don't know if it's the risk of interferences is increased. I would say that is lower because I mean the zone where the current can produce interferences is very small. And also we should remember that the most modern devices are really less susceptible to interferences. So I would think that this is the case for the leadless pacemaker.
Okay, a question from the audience. Is succinylcholine contraindicated in the patient when he is dependent of the pacemaker?
I think that we have an alternative to succinylcholine. So I would say yes. I mean, the risk of interferences due to fasciculation has been described. It's not systematic, of course, but we have rocuronium. So I would say that use rocuronium and avoid succinylcholine in this type of patients. And the guidelines are just mentioning the risk. Nothing more. Yeah.
Okay. Another question, I think it's a great question for you. Magnet on pacemaker for all patients, for some patients, and the question is risk of R or T phenomenon does exist when you put the magnet on pacemaker?
Definitely. I think that we should really remember that a strategy that would imply applying a magnet in all patients with a device is not a good strategy. Because first of all, some devices do not have magnet mode or can have deactivated magnet mode. This is the first thing. The second thing is that sometimes you have no way to check for successful application of the magnet. So it's kind of false sense of security. You put a magnet, but you don't know what is happening. Some device will produce an audible tone, but some don't. And finally, for pacemakers, switching a patient to asynchronous mode when you still have a native cardiac activity below can produce definitely at least hemodynamical impairment that was RNT phenomenon with VFib. So this should not be a good approach to this type of patient. I think that really magnets should be as much as possible limited to emergency context or really contexts that are motivated by the absence of recommendation from a cardiologist. That's why the recommendation, both European and American, to well identify someone in your network to help you, to advise you for those patients is, I mean, it's critical.
Okay, thank you. The message is quite clear. Well, gentlemen, we have finished in time. Although the technical problem we've got at the beginning. So thank you very much for this very nice session. We've got no more question from the audience. I check it. No more question. Okay, so I wish our audience will have a great continuation in this Congress. Take care of yourself and see you later in the real Congress of the SPHAR. Thank you. Goodbye.